Hi, my name is Emily Haltigan. I'm a second-year resident in internal medicine at the University of Florida. Today, I'll be presenting a case of refractory angioedema whom we were able to successfully manage in our outpatient allergy immunology clinic. Before I delve into the details of the case, I'll start with a brief introduction on the central topic of my discussion today, angioedema. Angioedema is a transient local swelling of subcutaneous and/or submucosal tissue that is due to capillary leaking in response to release of either histamine or bradykinin. Figure 1 demonstrates the most common areas affected by swelling. An urticarial rash may or may not also be present. Severe symptoms can even lead to airway compromise and require intubation. There are several causes, which include allergens, autoimmune disease, or complement deficiencies, both acquired or hereditary. However, a large number of angioedema cases, between 38 to 55%, are deemed idiopathic and no cause is ever identified. So how do we prevent episodes from reoccurring? For these patients, antihistamines are first-line therapy, and the addition of a leukotriene receptor antagonist may also be used. In those with symptoms that persist or recurrent episodes, corticosteroids are the next step. But what happens if patients become reliant on corticosteroids to control these episodes? The answer is that we really don't know, as it has not yet been well established. This leads me to present our clinical case. A 66-year-old female presented with 3-year history of episodic facial swelling. MRI showed diffuse nonspecific facial edema without mass. Imaging findings and biopsy results were consistent with diagnosis of angioedema. She had no prior ACE inhibitor or NSAID use. She underwent an extensive immune workup, which is seen in Table 1. This was largely unremarkable and included elevated not deficient complement levels, slightly elevated inflammatory marker of CRP, negative autoimmune panel, and negative genetic testing for type 3 hereditary angioedema. Thus, she was diagnosed with idiopathic angioedema. High-dose antihistamines, H2 blockers, and a leukotriene receptor antagonist provided no benefit in preventing recurrence of symptoms. She continued to have episodes at least twice per month. Ultimately, corticosteroids were started and her episodes resolved, but any attempt to wean them off was met with recurrence. She became dependent on the steroids and as a consequence developed insulin-dependent diabetes mellitus. A 3-month trial of an anti-IgE monoclonal antibody was also attempted without success. Several case reports had demonstrated success with Dapsone use in similar refractory cases, so the decision was made to start 100 milligrams of Dapsone daily. After 3 months of treatment, she was able to discontinue all prednisone without recurrence of episodes. Off steroids, her diabetes resolved and she no longer required insulin. At 5-month follow-up, her dose was weaned to 75 milligrams daily, and she has remained well on this dose at her 9-month visit. I'll briefly touch on the diagnostic workup for angioedema as highlighted in Figure 2. As previously mentioned, there's 2 main chemical pathways. The first is histamine-mediated. This is the pathway to the right that usually present with hives and is often due to allergens or drugs. This is treated with antihistamines, avoidance of triggers, and potentially use of IgE inhibitors. The bradykinin-mediated pathway generally presents without urticaria. The first step in distinguishing the cause is obtaining a C4 complement level. If this is low, the cause is further distinguished by additional complement level testing, which leads to diagnosis of either a hereditary or acquired complement deficiency. If there are no complement abnormalities, the differential includes ACE inhibitor-induced, type 3 hereditary angioedema, and lastly, idiopathic if all of the above are ruled out. In steroid-dependent cases like ours, additional treatment options are not well established, but more and more case reports are demonstrating success with certain medications. These include icabitant, a bradykinin receptor antagonist, rituximab, an anti-IL-20 antibody, and lastly, as we have demonstrated in our patient, Dapsone, although the mechanism is not well understood. Despite this, Dapsone appears to be a useful and safer alternative and warrants further investigation of its role in this setting. Thank you so much for taking the time to tune into my presentation. I hope you found this clinical case interesting and informative, and I appreciate having the opportunity to share it here today. Thank you.